Hello, Dr. Carrau. Nice to meet you.
Hi, Claudia. Nice to meet you.
Today will be our second meeting.
Okay. So I'm second at 5 then, because they told me I was gonna start at 4:30.
No, it's 5:30.
It's 5:30 yours, but 4:30 mine. No, because I won't be able to do it at 5:30.
At 5:30?
No,
Okay.
because I have another commitment. So that's why
But
when Gustavo told me he told me that I will do it at 4:30.
Okay. Because here our is 5:30.
Yeah.
Okay.
Yes. It's 1 hour
Okay.
difference. Yes.
Yes, but
Yes.
it will be on
Yes.
5:30.
That makes sense.
Probably we will have some problem with Dr. Juan because he has now surgery and believe that we just
Yeah,
will finish about 8 o'clock. So maybe we will do the first class with you. We will do a little time, and after we will again
yeah. The
reopen
problem is
for
he's in California. He's 3 hours
yes,
behind,
three
right? So
hours.
for him,
Yeah,
this is like the middle of the day for him.
middle of the day. It's very difficult to stop everything, but we have to try to learn
Sure. There's always
a little bit.
some glitch with this.
Yes,
It's all right. We survive.
yes,
Alex, I just saw you there for a minute.
yes. Very quick.
There you are. Good to see you.
I believe that your son had some problems with the sound.
Hello, Dr. Carrau.
Oi, Gustavo.
Thanks for taking part in this meeting. It's
no
really
problem.
important
No problem.
for us to
Sorry
have you here.
for the difficulties and all the back and
No,
forth, the times and now and the whole deal.
no problem. We know about your busy schedule. We hope you can join in future meetings also.
Oh, sure. Sure. I'll be glad to.
We are splitting this webinar in two parts. The first one is anatomy and approaches. And after this first part, we are going to get into some specific disease. And then it's really important to us to have you taking part also.
Sure, I'll be glad to.
We have also Juan Fernandes today.
Yeah.
And he told me some hours ago he had some huge case to operate on today, and probably he's going to get into the meeting just around 20 p.m. for us here, 8 p.m. for us here in Brazil. I think that we are going to have some break between your class and his classes, but no problem. Everyone is coming for the meeting, and I think that maybe in 20 minutes we can start. Okay.
Yeah, no problem.
20 minutes? No, 10 minutes.
10 minutes, yes.
I think Professor Vellucini is also here with us. I don't know if he's already inside the meeting.
I don't see him.
I think he's not here already. I am seeing Felipe also. Felipe is a close friend. He's spending some time in California right now. He's with Juan Fernandez. And then Felipe, what about your experience there?
I'm muted. Okay. Hey. So yeah, Dr. JFM is a bit busy at the moment, but I think that he'll be able to make it. Yeah. So right now I'm at the lab with the rest of the research fellows. So we're just waiting for you to start. And congratulations on bringing the society back to its tracks.
Yeah, I was just visiting Juan and all his crew in Stanford. Both Danny and I went to their course, and it was fantastic. They have such a great crew, and they're doing fantastic job there.
Yeah, sure.
Not unexpectedly, and not a coincidence, but it was great to see.
Yeah. We also are planning to have Daniel with us. Daniel is from here, Curitiba. We are in the same city, and he's facing some problems because also he has such busy schedule also. But we are planning to do a meeting maybe in October.
Excellent. Yeah, my wife is from Paraná too.
Oh, really?
Yeah. She went to medical school there in Curitiba also.
Do you come here often?
No, not very often, but we came. We visited last year, and maybe planning to do it again in the
Please.
next year. We'll see.
Now we have this phone contact. Then as soon as you come here, please let me know, and then would be a pleasure to receive you here for a dinner or something like that.
Thanks. We'll try. You know how family is. We're going back and forth. Her family is in Telemaco, Borba. So
yes.
we have to travel back and forth from Curitiba to Telemaco.
Dr. Carrau, we are going to talk a little bit in Portuguese because we need to fix some.
No problem.
But I know probably you are able to understand everything.
Yeah,
okay?
eu compreendo. Não falo bem, mas compreendo.
Perfeito. Ô, Cláudio. Cláudio?
O ID.
Claudio is going to be the host today, and he's going to present you and also the other speakers. And then I just need to pass with him this information that we need to do a break between your class and JFM class. We are also planning to do. Have you been in Foz do Iguaçu before?
Sim.
Yeah.
É muito bonito, muito interessante.
Muito bonito. Nós estamos planejando fazer o primeiro congresso da sociedade agora reativada, porque essa sociedade ela foi criada em 1986, né? E ela funcionou muito bem até por volta de 97, e depois ela foi inativada. Então ficou por 20 e pouco tantos anos aí isso aí parado. E agora nós reativamos, e o primeiro congresso nós vamos fazer em Foz, que foi a cidade onde a sociedade foi criada. E de repente, vamos ver, né, de acordo com a sua disponibilidade, tudo direitinho, a gente conversa, né? Mas se for possível, até de o senhor vir aí também no congresso.
Um prazer.
Vamos convidar. Venha com o Daniel e a gente pode fazer aí um.
Eu estive em Foz, mas estive no lado brasileiro, argentino.
Gustavo, só um minutinho, porque Velotini está tendo dificuldade no acesso. Deixa eu ver se eu... Você pegou o ID, né? Alguns problemas técnicos com o nosso moderador. We have some technical problems with Dr. Velutini enrolled to the meeting, so I will try to help him. Just a little moment.
Ô, Cláudio, é melhor você encaminhar então esse arquivo que eu te mandei lá, tá bom? Manda para ele aquele que ele faz o acesso direto.
Eu vou mandar por e-mail também. Um momento.
Isso.
Deixa eu ver se eu consigo. Ele realmente está tendo problema. Eu tive também, mas aí como eu comecei bem antes.
Também eu, né? Tuve que login.
O senhor conseguiu entrar perfeitamente, né, professor?
Pude, mas tuve que entrar também a login, não foi automático.
Ah, perfeito.
Eu consegui normalmente, eu consegui normal, Gustavo. Boa tarde a todos.
Então, eu mandei para o seu e-mail.
Eu consegui entrar normalmente.
Eu mandei para o seu e-mail e eu vou, de todo jeito, remandar o link também para o seu.
Agora o senhor tem aí 4h30 da tarde, certo, professor?
Sim.
Ah, perfeito. Aqui no Brasil são 5h30 e nós é um pouco até o pessoal está entrando aí, né? Eles disseram que teriam um pouquinho de dificuldade para entrar justo no horário, mas vamos seguir o programa direitinho para não tomar o seu tempo. Eu sei que o
Nós
senhor tem
podemos
compromisso.
esperar 5 minutinhos, não, sem problema. Sem
Tudo
problema.
bem?
Não vou
Perfeito.
falar por uma hora.
It's already.
Só isso.
Can you see me?
Oi, Velutini.
We had some problems with my connection. He
No
asked
worries.
for
No worries.
password that I didn't could find. How are you doing?
Doing well, doing well. How are you?
Fine. Danny is already good. Yes. Everybody's good in Pittsburgh.
Everybody's
In Pittsburgh, no, in Ohio.
Columbus.
Columbus. I'm a little bit in the past still. It's a vintage.
Professor Aldistan also sent me a message here. He's coming to see your presentation, and
cool.
probably in some minutes he's joining us.
Good.
Dr. Velutini, boa tarde.
Fala, Gustavo. Parabéns.
Obrigado.
Iniciativa.
Obrigado.
Até...
Pode falar.
Não, parabéns pela iniciativa. Até estava conversando com o Cláudio hoje, algumas sugestões aí. Resolveu o negócio do Juan Miranda?
Deu. Na verdade, assim, doutor, porque o Juan, a gente tinha confirmado há bastante tempo, e o Dr. Carrau, ele tem um compromisso depois da reunião aqui, então ele precisou que fizesse um pouquinho mais cedo, né? Só que o Juan tinha um caso para operar grande lá e ele não vai conseguir entrar no horário. Ele disse que ia fazer de tudo para conseguir entrar o mais rápido possível, mas provavelmente ele vai ter alguma discrepância de tempo. Ó, o doutor Aldo está conosco
Oi,
também
Aldo.
aqui.
Olá,
Olá.
Ricardo, como andas?
Tudo bem, tudo bem.
Bem, bem,
E
bem.
você?
Ficando mais viejo?
Ah, também. Sua família, todo mundo bem?
Tudo bem, graças a Deus. O único mais velhito aqui sou eu, o demais está indo bem.
É,
Os netos estão vindo melhor.
mas a alternativa não é muito boa, hein?
Não, alternativa não há alternativa. Temos menos tempo de vida todavia, mas está indo bem,
É,
tranquilo.
é,
Continuamos pescando muito.
isso,
Isso é o mais importante.
magnífico.
Mais pesca que cirurgia.
É. A cirurgia virou um hobby. Pescaria virou profissão. Muito bem. Obrigado aí, Gustavo, pela iniciativa.
Não, obrigado, senhor, doutor Aldo, aí por também acreditar aí que a gente pudesse tocar esse projeto, né?
Claro, sem dúvida nenhuma. Você vai tocar e muito bem, tenho certeza.
E assim, a gente conta aí com o apoio do senhor. Até como eu falei para o senhor, no dia 15 eu estou indo em Foz do Iguaçu para organizar lá a questão do congresso. E assim que o doutor Velutini também é nosso conselheiro aí permanente, né? E assim que nós
Palpiteiro.
conseguirmos e assim que nós conseguirmos organizar lá, eu quero fazer uma reunião com vocês para a gente organizar a melhor forma, né? E data também, tá bom?
Carrau, you know that the Brazilian Skull-Based Society was the first, before the American Skull-Based Society, where Brazil was created in 1988, and then stopped it for some reason for more than 15 years. Now Gustavo is rebuilding with Claudio and a lot of people rebuilding the Brazilian Skull-Based Society.
That is excellent. There is a young guys have to rebuild it again.
And you are part of this beginning. This
Anything
webinar,
I-
a part of
I'll
the
be
beginning.
glad to help in anything I can.
Yeah, thank you. Gustavo está no mudo.
Perfect. Dr. Carrau, we have already 32 people attending to the meeting, and I think that we may start to do not delay your commitment later.
Thank you, Gustavo. And I'm gonna try to share my talk here. So hopefully you can see it.
Yeah, yes, we may see this perfectly. Yeah.
Excellent, excellent. So I think that with 30 people, we can have an interactive type of conversation. So if somebody has a comment or wants to some different or ask any questions, you can interrupt me and we can talk a little bit. Today, I really want to talk about fundamentals of the transcrival approach, and I'm going to show you a bunch of cases and just going to talk to you about the anatomy and how we think about this. So basically, as we all know, Rotten back in the day described the clivus as three parts: the upper clivus, that is basically the posterior clinoid, middle clivus, and then lower clivus, which is really the craniovertebral junction. When this was described, that was described from the open approaches standpoint, and then came the endoscopic, and we have to really use the same concepts from the endoscopic standpoint. So basically, this is something that came from Broughton's lab, and it may have been Juan Fernandez Miranda who gave me these slides, or may have been Danny. But basically what it shows is that basically all these three areas correspond to an area within the nose. So the upper clivus corresponds more or less to the superior turbinate. The middle clivus corresponds more or less to the area below the superior turbinate and going down to the inferior turbinate. And when you look into the sphenoid, it corresponds to the floor of the sphenoid. not the floor within the sphenoid sinus itself, but the floor that really corresponds to the roof of the nasopharynx. And then you have the lower clivus that, as I mentioned before, really corresponds to the craniovertebral junction, and it will have some important landmarks that we will be talking about. So when we look with the endoscope, this is really what we're going to see after we remove the bone. So we have the sella turcica, and behind is going to be the posterior clinoids. We're going to have the clivus proper in between the two paraclival carotid arteries, and then the lower clivus. So more important that these superficial landmarks is really what is behind. So as we look from the endoscopic standpoint, from anterior to posterior, we'll see that every one of these aspects are associated or linked to a vessel, at least a vessel, and a cranial nerve or several cranial nerves. So we have here that the posterior clinoids or upper clivus are associated to cranial nerve number 3, and then you have the posterior cerebral and the superior cerebellar arteries that kind of serve as a gate for that cranial nerve number 3 to go through. The hallmark of the middle clivus is really the basilar artery, and then you have the cranial nerves number 6 that go from the brainstem into the Dorellos canal. And then on the lower clivus, we have the lower cranial nerves, the vertebral arteries, and of course, we have the hypoglossal canals that are part of the lower clivus. So we'll talk about this a little bit more in a second, but I want to call your attention that these cranial nerves make a corridor. So anything that is in medial to that corridor is ideal for an endoscopic approach. As a lesion goes lateral to the corridor of the cranial nerves, the endoscopic approach presents less of an advantage because you're going to have to be crossing the nerve. And of course, we cannot forget the vessels. Fortunately, many times the vessels are posterior to the lesion that we have to remove, although in many cases, some cases that I'm going to show later, the vessels are going to be very much associated with the lesion, and this needs to be taken into account. So let's go into a little bit more detail. Let's go into the upper clivus, as I mentioned, the third cranial nerve. And to get a view of that, like this one, where we have the third cranial nerves and the superior cerebral arteries and, the posterior cerebral arteries and its superior cerebellar, and you have the mammillary bodies, you have to remove not only the clivus itself, but anterior to the clivus, you have to move the sella out of the way. So you have to move the pituitary gland out of the way, and there are a variety of ways of doing this, one of which is the pituitary transposition that I will mention later, but this is not the only option. So if we're looking into this area, we see also the cranial nerve number 3 as it goes into the cavernous sinus, and then it comes anterior to the carotid, and other landmarks that we're going to be seeing from different standpoints. And these landmarks have to be kept in mind as we're looking at the lesion. And remember that this is normal anatomy. The lesions in this area may actually distort the anatomy in such a way that the relationships may change a little bit. So when we look at the different imaging that we have, we try to guesstimate where are the cranial nerves moving, and sometimes we cannot do that accurately. So on the middle clivus, as I mentioned before, we have the basilar artery and the 6th cranial nerve. And the 6th cranial nerve, we divide it in 3 aspects. We divide it into the cisternal aspect, then the intradural aspect, and then the part that is going to be in the Dorellos canal and into the cavernous sinus that we will look at in some slides further on. But just remember that we can see the cisternal aspect, but many times we forget about this intradural aspect. So as you're opening the dura toward the carotid, you have to remember that the 6th cranial nerve may be in between the leaflets of dura. And this is important so you don't cause an inadvertent injury, even when you have the cisternal part well in view. And then again, in the lower clivus, we look at a close-up view of the same thing. You have, again, the vertebral arteries. You can see that the basilar artery forms more or less at the level of the petrous carotid. So if you are below the level of the petrous carotid, you should be at this level. You have the ICA and the PICA, and then you have the variety of all cranial nerves from going into the internal auditory canal, the 7 and 8, and then going 9, 10, and 11, going into the jugular foramen, and 12 with its own foramen at the level of the lower clivus. So a much more crowded area in regards of the cranial nerves, and you can see the posterior and anterior relationship with the PICA and the ICA that these nerves have. So in summary, with all this, we should remember the relationships of the nerves that are associated with each part. And again, remember that this association may change according to the lesion that we're dealing with. So let's go in a little bit into surgical anatomy and a little bit of technique on how we get there. So here we have a sphenoid sinus, which is fairly well pneumatized. You can see the carotid arteries, and you can see the optic nerves and the different recesses that we have with the optic strut well pneumatized, et cetera, And here what we're going to have, if we're going to eliminate all these septations, so we have an in-plane field, and we're going to have a transtuberculum and transcellar approach. So the bone of the tuberculum and in front of the sella turcica have been removed. And we're going to open the dura of the sella to then separate the pituitary gland from the dura. And this is a description that goes back to Amin Kassan, that he described the so-called ligaments joining the tunica to the dura, and he described the transposition of the gland. Now, if you look at this picture, you will see what is the main problem of this technique, which is that you have to divide the inferior hypophyseal artery in both, maybe in both sides. And when you do that, the chances that you're going to have diabetes insipidus is actually very high. You're going to devascularize the posterior gland, and you can cause some trouble. So this technique has been later on modified to avoid this type of sacrifice of the inferior artery. The other problem that it has is that when you do that, you have basically remove all the venous return out of the pituitary, which is also a cause of maybe apoplexy and maybe problems. But nonetheless, here you have an example of how the pituitary gland is being moved away from the dura. That you have the so-called ligaments that are really more areolar tissue than anything else. And you're going to do that more or less 360 degrees if you would like to do the transposition in a traditional way. But as I mentioned before, what is done nowadays is that you leave the dura at the inferior aspect of the pituitary, and you move the pituitary with the dura, or you just do it in a completely extradural fashion, which say it doesn't have the problems of diabetes insipidus and the dysfunction of the pituitary gland. So once you have done that, you have the potential of taking out the posterior clinoids and then having the view like that, which is really what we want to expose. We want to expose the area of the mammillary bodies and cranial nerve number 3, and et cetera, at the tip of the basilar artery, et cetera, et cetera. So here you have a clinical example, and in this particular case, you can see that the dura in the inferior aspect has been left intact, and the dura posteriorly is also going to be intact. So you have some type of venous return of that pituitary, and the inferior hypophyseal artery has been mobilized bilaterally, but it really have not been sacrificed. So as you do that, and you move the pituitary gland superiorly, then you're going to expose the posterior clinoids in the back. Oh, let me go back a little bit. And basically, what we try to do is divide the clinoids in two. So we're going to remove one clinoid at a time. And the reason for that is, if you try to remove the entire complex of the posterior clinoid, you have to form kind of a seesaw and cantilever back and forth. And the problem with that is that the tip of the clinoid is going to be your cranial nerve number 3. So you can actually injure the cranial nerve as you do that. So it's better to divide it in two. The other issue in here, the other anatomical entity here is the carotid artery that is going to be lateral to the clinoid. So you want to really separate that clinoid very well before removing it, so you don't cause an injury, an inadvertent injury of the carotid artery. So here you have one of the clinoids being taken out, and you can see that it's being separated carefully as it's taken out of the view. And once you have repeated that bilaterally, then you can open the dura, as you see here. And I'm not gonna dwell too much in technique, but basically, this is a case of a craniopharyngioma that is gonna be exposed. And as you can see here, also supetimes depends on the lesion that you have. It may be that you not only have to open the posterior, the superior clivus, but you may have to extend your resection to the middle clivus. And as you extend your resection in the middle clivus, this is a problem that we encounter very often. This is the venous bleeding from the basilar plexus. And in the past, this would create a major headache for the surgeon, and it would take a while to control. Nowadays, with the different hemostatic pace that we have available, you can control this very easy. And what this will give you is a more caudal to cephalic type of point of view. So it depends on the lesion. You may be able to remove the lesion and take a look at it a little bit more in a more panoramic view, as you can see here, following the basilar artery and the cranial nerve number 3 in a way that corresponds very well to the anatomy that we saw before. Later on, after removing the tissue, this is just the view of the ventricles, third ventricle, as the lesion was removed. So again, going a little bit further down, going into the middle clivus, this is basically going to be the part of the bone that is in between the two carotids. And in this particular specimen, you can see that it's fairly pneumatized, but sometimes, as is going to be the case in the clinical case that I'm going to show you, the pneumatization is not so good, and you will have some problems identifying the carotid artery. As you open the dura in this area, again, you have to consider where the lesion is and how the sixth cranial nerve is going to be moved with the lesion. If at all possible, you could open the dura in the middle and then try to identify the sixth cranial nerve. I told you already that the junction of the two vertebral arteries is more or less at the level of the petrous carotid artery, and which is more or less at the level of the floor of the sphenoid, not again that floor that you see at the level of the sphenoid sinus, but the floor in the bottom. And this is more or less where the sixth cranial nerve is going to take off. So using those superficial landmarks, you will be able to try to identify them and identify the parts that we talked about before, the cisternal, the interdural part, etc., etc. So this is a work by Ricardo Dolci when he was here in Columbus, and basically he looked at the different configurations that you can have for the clivus that is formed really by the geometry of the carotid artery. So you can see here that the carotid artery can have kind of a cobra type of configuration, and it forms a kind of an hourglass type of clivus as you drill it. It can have this type of a square or trapezoid, and the configuration also of the quadrangular space also is going to change according to this configuration. So something to have in mind as you are trying to drill and as you're trying to have this anatomy kind of reconstructed virtually in your head. It is useful to have this configuration on how is going to be the shape of the drill clivus that you're going to have. Now, if you don't find the landmarks for the carotid artery, obviously we have some ways of identifying it. Usually we just follow the Vidian, and I'm not going to dwell too much in this particular aspect, but to follow the Vidian artery, basically we go into the pterygopalatine fossa. The main landmark of that is the sinopalatine foramen with the sinopalatine artery that is identified because it's just posterior to the maxillary sinus and is at the upper third of the maxillary sinus. As you can see here, you can identify the foramen, control the artery, and then go into the pterygopalatine fossa. As you go into the pterygopalatine fossa, you're going to find the vessels anterior to the nerves, and the VDN nerve is going to be looking away from you. So if the sphenopalatine foramen is really at the same geometry as the lateral wall of the node, so it's going to be you're not going to be looking at the foramen itself. It's going to be sideways to you. The VDN is going to be like two little eyes that come. So this shows that configuration where the artery with the sphenopalatine, it comes sideways into the nose, while the VDN is just a straight. Same thing in the imaging here in the CT scan. You can see the VDN artery joining the petrous carotid. By the way, the most reliable landmark is really the nerve. The artery is present in about 40 to 60% of us, but the nerve is present basically in 100%. So when we're talking about the artery, we're talking about the neurovascular bundle or the canal, the VDN canal, which is really what we follow back. So as we follow that VDN back, it's going to take us to the horizontal carotid. This is just to mention that we have talked about this in the past, about whether you drill at the top or you drill at the bottom of the canal and which one is safe. The truth is that you drill both at the bottom and at the top in a sequential fashion, and both will safely take you to the carotid if you take your time and you drill sequentially and cautiously. The VDN nerve is going to cross the petrous carotid artery right on top. So if you imagine going at the bottom of the VDN canal, you are going to find the petrous carotid artery eventually. If you follow it at the top, you will also find the carotid eventually. So it doesn't really matter that much. So here's a view of that relationship of the VDN with the carotid. And basically, we're looking at the right side with a 30-degree scope looking to the side. So you have the paraclival carotid, you have the petrous carotid, and here you have the VDN carotid, the VDN artery, which you can see that comes to the transition of that paraclival artery, paraclival segment, and the petrous. You can also see that V2 that is going to the Gasserian ganglion is going in the same direction. So the nerve is not shown here, but the nerve is going to be sandwiched in between the Gasserian ganglion and the carotid. The bone in between these two is a bone that is wedge shaped, and you can also use it as a landmark. So using, even when we talk about the VDN, the truth is that we use the VDN canal, the V2, and the bone in between to follow it back and to get into this transitional area where you have the petrous carotid and the paraclival. So now we're looking on the left side, basically the same deal, just to show you another view of how the Gasserian ganglion is over here. And now you can see a little bit more of that sixth cranial nerve in the interdural portion. And as it goes into the duratus canal and comes out in the carotid sinus, you can see that is the nerve that is closest to the carotid artery. So here you have a case of a chordoma. It's both intradural and extradural. And I'm going to try to let it run here. On this particular case, we were not as lucky with the sphenoid sinus. There's a lot of partitions and a lot of, it's not very well pneumatized. So we have to find the carotid arteries on the same, using the landmarks that I mentioned before. So here we are just forming a clival recess that it was not there before, identifying the carotid. So here's another way of identifying the carotid. This is Danny doing the dissection, and this is something that I learned from him. Really, is that he finds the floor of the sella, and then by dissecting the dura of the sella upward and laterally, he finds the carotid canal as it comes paracellular. So let me see if I can show you that again. So you have an idea. There it is. So as he follows it and lifts the dura up, you see that transition, that curve that forms the carotid canal. So obviously I'm showing it to you once he has dissected it a little bit more. Let's see if he has a little bit more. There we go. It's still quite dissected. Well, you get the idea, is that by looking at the floor and looking laterally, you can identify the canal. So again, I'm not going to dwell too much on technique here, but basically we're following the tumor from the extradural part to the intradural part. And this is a patient that had a little bit of brainstem compression, and we were not sure of whether the basilar artery was going to find, where we were going to find the basilar artery in this mess on the sixth cranial nerve. So we're going very slowly. Now we see the basilar. We know again that that sixth cranial nerve is going to be more or less taken off at the level of the floor of the sphenoid sinus, or at the level of the transition between the basilar and the vertebrals. So we're looking at that point, and the sixth cranial nerve, I don't know if you can see it there on the side, is identified, at least on that left side, and the dissection is continued. This dissection was extremely prolonged and tedious. You can see here how Danny is still dissecting tumor from the basilar artery. And basically, this was more or less at 10 o'clock at night when we're doing this dissection, trying to push each other to do the best we can for this patient. This patient was, at the time of surgery, I think she was 20, 21. We just saw her in the office. She's 5 years out and no recurrence. So once you do that, then you have to think about the reconstruction. For the most part, most of these cases are reconstructed with a nasoseptal flap and fat. So I think that Aldo may have been the one that termed this the three Fs, right? So flap, fat, and fascia. We don't use fascia very often. We use collagen, but it's basically the same concept. So the concept here is that you have a very long tunnel, and the tunnel is so long that if you try to put the pedicle flap inside that tunnel and come out in the other side, the flap may not be long enough to do that. So basically, you try to stop the CSF flow by using collagen or fascia, whatever your preference is. Then you use abdominal free fat to fill up the tunnel, and then your flap comes on top of that. So at the end, it will look at something like this. This is not the same case, but there's fat behind it, and the flap goes on top. So something that we discovered, and this is something that our colleagues from Pittsburgh has documented in a nice report, is that on the cases that we do not use fat, the brainstem tends to herniate forward. So nowadays, we use fat even when we have a flap that may be able to cover the entire tunnel. So we're not entirely sure why this happens, but I think that the fat provides a little bit more bolster and more support. So here you have the same case pre-op with the post-op with some fat inside the tunnel, and then the flap reconstructed. She actually had a CSF leak post-operatively that we had to repair, but after the repair of the CSF leak, as I mentioned, she did very well. So moving further down into the lower clivus, basically moving into the craniovertebral junction, when we look at this area, we have the craniovertebral junction is going to be at this in between the eustachian tubes. C1 is going to be more or less at that level, and you have the odontoid process behind. Even when we did this in this cadaver, but if we're going into a pure lower clivus approach, as I'm going to show you in a couple of cases, we really don't have to open the sphenoid sinus, and in many cases we don't have to do as big of a septectomy as we have here. With a small posterior septectomy, is fairly feasible to go back and open the pass. So I'm going to skip through some of this and just show you this particular case. This is the case of a meningioma in the lower clivus and craniovertebral junction, including behind C1. So let me stop here for a second and show you, in this particular case, we're removing the mucosa, but nowadays what we try to do is an inverted U-shaped type of flap that we put a suture, and that suture is brought into the mouth and is pulled down. So you have good access to the area. And at the end of the case, we're going to use that flap to cover the area. So in this particular case, we didn't do that, and it worked. We had a flap, an nasoseptal flap that actually covered the area. But is this inferiorly based or inferior or inverted U flap? It gives you more security that you're going to have a better coverage at the end of the surgery. Sometimes the nasoseptal flap is not good enough or it's not long enough to cover the most inferior aspect. So again, once the bone has been removed, taking care that we do not go laterally into the hypoglossal canal, the dura is exposed, and again, I'm not going to dwell too much on this. The lesion is exposed and resected in the same fashion as we showed before, just showing the vertebral arteries at the end after the resection. You can see here the accessory nerve already coming out, and you get the spinal cord at the bottom there. So something to have in mind, depends on how low you want to go, is how the palate is going to impede your inferior access. So basically, this is the nasopalatine line. If you throw a line between the tip of the nasal bones and the posterior aspect of the hard palate, that's basically the inferior aspect of what you can reach with an endoscope. Now, there are some ways of circumvent that or extend that by using an angle scope, inverted, and using an angle drill. But for the most part, you're gonna have that's what you can control from the endoscopic standpoint. So here we have one more case, and then again, skip through this for the sake of time. And just show you the lesion itself. And I'm just going to say the reason that I put this is that we did not have a nasoseptal flap that was low enough to reconstruct this particular defect, because on this one we took down C1 and we had to take the odontoid too. So here's the meningiomas, we are taking it out, but at the end we had to reconstruct this with free fat, which worked because we have such a long bony tunnel that it was able to reconstruct it in an adequate fashion. Oh, I think that I'm missing a slide here. I apologize, but I think that basically we can maybe stop here and try to entertain any questions or comments and try to discuss a few more aspects of this in a more interactive discussion. Let's stop the share.
Perfect, Professor Carrau. I will ask Claudio to present our invite here.
Okay. Okay. Dr. Carrau is a world-renowned ENT professor at the Department of Otorhinolaryngology, Head and Neck Surgery at the Ohio State University, director of the Comprehensive School-Based Surgery Program. Dr. Carrau is one of the pioneers of Indonesian endoscopic applied to the school-based lesions. His work was fundamental in spreading the technique, not just in the Americas, but around the world. Dr. Carrau has some hundreds of published articles about endoscopic surgery. But I want to call attention for one that, for me, is a seminal work. It was published in 1997 together with Dr. Joe, which was the first major series of application of the endonasal endoscopy for transsphenoidal surgery. I believe that it was a type of milestone in the history of endoscopic surgery. And since then, he has been working with very brilliant neurosurgeons like Dr. I forget his name. The second one from yes, Dr. Kassan in the Pittsburgh area, and now he has been working with our Brazilian colleague, Dr. Prevedelo, and it's a great pleasure to have you here sharing your vast experience with us and give that gift that your experience to our society. I will open for our moderator, Dr. Velutini, that is okay.
Yes, let's invite Professor Velutini to do the comments, okay?
Yes, okay. Let's go now for Dr. Velutini. That's another very recognized neurosurgeon in school-based, one of the biggest experience in Brazil. Dr. Velutini, please, it's your time.
Thank you, Gustavo. Thank you, Luis. I think that's is a very nice return from the Brazilian Skull-Based Society. These webinars that you are organizing, since you are bringing very important people, historic people from skull-based surgery, endoscopic skull-based surgery, like Ricardo L.Carrau, as you told, Joe and Carrau, Clivus chordoma through transnasal endoscopy was the first paper and was the paper that opened our mind, our view, our eyes for the transnasal endoscopic approach for those tumors. So Carrau is a milestone in the endoscopic skull-based. And when we restart the Brazilian Skull-Based Society with such a speakers, I think we are in the correct way. And as a moderator, I have some questions, but we have some nice, very talented surgeons here, Aldo Stam, a lot of them here, and Mariana, and we should have opened for this, have some comments, some questions, and I have some questions, okay, I'm gonna ask and Carl, and first, you gave some tips to find the intradural sixth nerve, okay? You see the floor, sphenoid sinus, the junction of the vertebral arteries, the mitral arteries for intradural. Which are your tips to find the extradural sixth nerve behind the carotid artery? At what level of the middle clivus, how can you find it? Because sometimes we don't open the dura. We go only extradural, and it's very important when the tumor goes lateral to have some tips in anatomy to find the sixth nerve.
Yeah, that's a great question, and I wish I would have a specific landmark that I can give you, and will give you the answer to that. But the truth is that if we are completely extradural, we don't care too much about where the sixth nerve is gonna be, because the chance of hurting it is actually very low. And there are some cases that are extradural, and you have to move toward the Morelos canal, and the tumor goes into the carotid, and that becomes into play. But for the most part, those are the least number of them, I suppose. Nonetheless, but things that we do is that we use EMG during the case, and we have a stimulator. And once we are passing the carotid, and we're past in that aspect that is of the dura that is behind the carotid, then we start looking for some type of marking on the dura where you could see the nerve. And in some patients, you can see it well. In many, you won't be able to see it. But using the stimulator, you may have a better idea on where it's going to be. So nowadays, Danny is experimenting with an ultrasound that is very useful to see in the nose, and he has shown that sometimes you can see the nerve also. Now, and I emphasize sometimes. I don't know yet if that sometimes is because of our lack of expertise, and it is possible to identify in most of the time, and we just are not good enough to do it yet, or that the technology is not good enough to identify. But between those two are the things that we rely now on where to find how to find the nerve. And as we go lateral and then we go into Dorelo's canal, we continue to follow again with the monitor and the stimulator and try to find it that way. And of course, careful dissection goes without saying. That's what we do. Yeah.
Okay.
So
Thank you.
Nothing magical. Sorry.
Does anybody, Aldo, have some comments and questions for the presentation? And who else is there?
Congratulations, Ricardo. It's a great talk. I think it's one point, especially this question that Dr. Bellutino mentioned, is very, very, very difficult to answer. I agree completely, because this is the most difficult part, especially extradural lesion. Probably Dr. Bellutino mentioned regarding the chondrosarcomas located in lateral portion. The extradural lesion usually involve the sixth nerve in this part. So you try to identify the Petrus process of the sphenoid bone. It's a very reliable landmark to find the nerve, and then you follow it. Don't forget that the nerve crosses behind the internal carotid artery. Sometimes it's possible to see when we elevate the internal carotid artery, but usually it's not easy to find extradural portion, especially when displaced by the tumor, or huge chondrosarcoma displaces the nerve more laterally, so it's not easy to find it.
And it changes the dura, and it becomes like dirty when the tumor is there. It's not an easy task. Definitely not an easy task.
Yes, I agree.
So I want to, before I forget and we go, I want to thank everybody for the kind words, and I have to say that it has been a lot of fun. Sometimes life opens doors that you're not looking for, right? Being at the right time and the right moment, and being with the right people. So it's now that I have Aldo in the screen, we go back to 1994 to a trip that we both had in Cartagena, and we started commenting about different approaches and juvenile angiofibromas and inverting papillomas and chordomas and this and that, and we have been basically learning from each other ever since, exchanging ideas, and not only with Aldo and Bellutini, but the other people around the world. And that made it extra fun, and made it also possible. All the things that we see nowadays is really the work of many people thinking from different perspectives at the same time on how to solve a problem with the tools that we had at the time, new tools that we had at the time. So I encourage the new people, the new generation. They're going to have also new tools, but I think that the key to this was really being able to recognize that the anatomy doesn't change. If the perspective of the anatomy may change with the different tools that we have, but if you have the fundamentals, you will be able to tackle lesions in a 360 degrees around the skull base with whatever tool you have at hand. And that's the tools will continue to change, technology will continue to change, but the foundation on how we use those tools won't change. So I want to again here in public thanks Aldo and Bellutini for the great friendship and great again exchange of ideas that we have had throughout the years.
Thank you, Dr. Carrau. But if some of the participants have some questions, please put in the chat, then we'll send this to Dr. Carrau. We have a question from someone. Do you always look for the median nerve before paraclival carotid exposure? When you do a middle clavicle craniotomy, if so, where to start looking for the median nerve? I always say,
yeah, it's a great question. Great question.
Just a moment. I
Yeah.
always say it's much easier to find a carotid artery than a median nerve.
Yeah.
Most of the time.
Well, it's just a matter of perspectives, right? It depends on the case too. Well, but basically, the short answer is no. We don't find the median nerve for every single time that we go there. If you have a very well pneumatized sphenoid sinus, you will see where the carotid is. This is not necessary. The median nerve becomes a more useful tool when for cases that are not well pneumatized, that you have to really find the landmarks with the drill. That's when the median nerves comes into play. And again, we talk about the median nerve, but it's not just the median nerve. We look at the median, the V2, the bone in between, and nowadays we also use we go into the basopharyngeal fascia and we follow it up to also find the petrous carotid artery. So between all those landmarks, you triangulate. Where do you find the median nerve? So there's a little bit of confusion with the median nerve, part of it because of things that we had published in the past. As you look inside the nose, only in a nasal corridor, and you extend your sphenoidotomy laterally, you may find a little, what seems to be a foramen with a small neurovascular bundle. And at the beginning of starting this adventure, we call that the median, but that is not the median. Nowadays, we recognize that that's really the palatovaginal fissure with the pharyngeal artery. The median is going to be lateral to that. So for the most part, for most people, you have to go inside the pterygopalatine fossa to find the median. So the easiest way is just remove the anterior part of the sphenopalatine foramen, move your sphenopalatine and posterior nasal arteries down or up, and the median is going to be behind it. Another way is you find your palatovaginal fissure with the pharyngeal artery, and you go lateral. The pharyngeal artery is usually a branch of the median, so of the median artery. So you will find that as you go lateral, you will find the foramen. So those are the two things that we do to find easy. It is easier if you are subperiosteal, so than if you are trying to dig through the fat of the pterygopalatine fossa. So if you keep your dissection subperiosteal on the back, you will be able to identify it in a much easier way.
Thank you. We have some questions, as always, about reconstruction.
Yeah.
Aldo, could you comment this about reconstruction, all the difficulties, all the possibilities? Because we used to reconstruct as you do. Yeah, we used to put fat, fascia, the triple F, fat, fascia, and flap. Most of the time now we substitute the fascia with some dural substitute, and then fat and flap. And then there's the question about lumbar drain and in recurrence when you don't have all of this. Maybe Aldo could comment something about this, and then.
Yeah, Dr. Eduardo. This is probably the most difficult problem is reconstruction, especially the posterior fossa. Ricardo knows about this. The posterior fossa is always our problem to solve. Basically, we have two big problems in the reconstruction of posterior fossa, especially reoperations and patient with irradiation. The combination of the reoperation and irradiation is really difficult to close it. Sometimes we use 2 layers of fat in order to put the defect more anteriorly. It works. So you put one layer of fat, fascia, and then another layer in order to put the defect more anteriorly, more superficial, in order to cover with the big flap. Many times you have no more nasal septum. flap. You need to use a lateral flap, or even another structure like periosteum, etc., or muscle, even transfer. And in our experience here in São Paulo, we have some difficulties, especially when we have no material for reconstruction. I think one important point is, if you have no way to do the reconstruction through the nose, no way, it's difficult to say no way, but sometimes it's extremely difficult. I think it's better to opt for another approach if you have impossible to do the reconstruction of some limitation, very limitations. You try to use now, Ricardo, more and more muscle transfer with microanastomosis very early, not the later one, after the patient presents many complications like meningitis, ventriculitis, etc., etc. So you try to use it before, and in our experience now, to do the more early this operation, change completely the future of this patient. So I don't know if you agree with me. So you have many problems. The other problem is patient with meningitis, for example, that increases the depression. In this patient, sometimes it's necessary to use external derivation and then try to close it. Otherwise, it's impossible. Put everything you have in your room, you don't close it. So for us here with Dr. Velutini, especially is how to close this defect in posterior fossa. The anterior fossa is a little different situation, but the posterior fossa for us is the most difficult point of the CSF leak. I don't know if you agree with me.
Yeah, I think that we deal with the same situations, right? The same situations, and you have the same options to reconstruct. It's just a matter of which one do you go first. We don't go so much to the free flap reconstruction early. We leave for us it's still as a last approach, but without question, in those patients that are recurrent, that you already failed twice and you don't have a good flap, and that's the main issue, is you don't have good vascularity and you have osteoradionecrosis from prior treatment, a free flap is the way to go. And usually we use lateral thigh muscle, anastomose into the neck and brought through the retropharynx into the, so it's brought directly. And that solves the issue not only of the CSF leak, but also of the osteoradionecrosis, which is another problem that these patients have with exposure of bone and pain and all kinds of other misery that they may have from the treatments that we have used in the past. So in our algorithm, we use nasoseptal flap when we have it. I either go to a lateral nasal wall or in a temporoparietal fascia flap, depends on what we have. In some patients, those options are gone. They were used already. The patient has a bicoronal flap, nasoseptal flap is gone, the lateral nasal wall is small, so free flap is the way to go, as you mentioned.
We have a question from Gustavo, and I think it's a very interesting question because for clival or petroclival meningiomas, when you decide, because you show the case that you open C1 and odontoid process from, you set the limit of the nasal bone and you but went through the C1 and odontoids and you create an instabilization. So
that particular patient already had some issues that had already had a fixation. So that was not an issue, but you are absolutely right. That's a great point that I didn't discuss. If you're gonna cause instability with an endonasal approach, it's better to go through a lateral approach to do it. And that's really the way that these cases, as you know, are really the decision making is mostly on Danny's side than my side, and that's the way he thinks, is that if we're gonna cause instability, it defeats the purpose of the endonasal approach. It's better to come from the side.
And do you have some limits for the lateralization of the tumor? I would say to Gustavo that's the petroclival is not the good tumor, but the clival tumor, clival meningioma, the middle located is the perfect
Yeah, it has to be, as I mentioned, it has to be medial to the nerves. If it is medial to the nerves, you're good with the endonasal. If it goes lateral, you may have a problem. And some of them may allow you to do it if they are soft and you can suction them out, but that's not the case in most of them. So it's good to consider a different approach.
I would say for petroclival lateral meningiomas, we have done once petroclival meningiomas, lateral approach, and there was some residual tumor in the clivus, very anterior, we could not remove. Then it has grown, and then we, in the second stage, after 2 years, we went through a transclival approach for this. There was a middle clivus tumor, not lateral.
Yeah, and that's another good point, that many of these tumors that are benign, you can use a stage type of approach. You can do it in different 2 stages, or you can use non-surgical means, radiating the remnant.
Yes,
you have some other options. So the idea is really not to have the idea is to have a great functional patient at the end, not really a great image that it looks perfect, but the patient is devastated with multiple cranial nerves deficits and really poor quality of life.
Another question, Rafael, have you seen when you do the inverted U-shaped because of flap to a person in inferior clivus, how do you detect it from the bone? He has tried above it, but oftentimes the end is, the flap is burned.
Yeah. So
it?
Good question. And yes, so the inverted U flap is easy to dissect from when it's from the posterior wall of the nasopharynx. And at that point, you're not dissecting it from the bone, you're dissecting it from the muscles, from the capitae or the longus colli muscles. So you're basically have a mucosal flap. And the muscles, you can do whatever you need to do with them. But the flap is pure mucosa, and maybe mucosa and fascia of the muscle. The problem comes when you're trying to have an extended flap and dissecting it from the roof of the nasopharynx, and you're going to be dissecting the basic cranium, basically, and that fascia may be very adherent. And sometimes you can do it, and sometimes it's going to shred. Especially in people who have adenoidectomy in the past, it may shred, and you may not have a beautiful flap at the end. So the flap that I mentioned is really from the posterior aspect. We have tried to make it longer on the roof of the nasopharynx, but I have to say that we're successful on bringing that part maybe in 50% of the time. The other 50%, it looks terrible. It looks like a potato chip that has been chewed up.
No other question. I think that's your. We had some patients that had brain herniation for clival tumors that go intradural. Although we put fat, we always put fat in the clivus. And when they had some brain herniation, brainstem herniation, but looks terrible in the MRI.
Yeah.
But no clinical significance.
Yeah, same. So the people that you put fat has less of a risk of the herniation. It's not 100% though. We have the same issue. We have had patients that we put the fat, you can see the fat, it's still the brainstem herniates, and it's a scary image because you see the brainstem inside the sphenoid sinus, but yet they have no dysfunction whatsoever. Yeah, I agree with you.
Okay. Aldo, some more comment, Aldo? I don't know about the time because you have some.
No, I'm happy. Thank you again, Ricardo. It's a fantastic lecture. Every time I learn a lot from you. Just a comment. Just behind you have two posters. One superior is posterior fossa, just behind your head.
Yeah.
Your inferior is the cavernous sinus. I have both. It's a fantastic drawing. It's really fantastic. Just to mention, the first anatomic slide you show, a lateral view. Remember the first one?
Yes.
Yeah. This was dissected exactly 20 years ago, 23 years ago, in Gainesville with laboratory Professor Houghton. And who did this cut was Alberto Capel. Capel worked with us. He's did this dissection fantastic. And I was very happy because many people around the world use this image from the lab.
Yes, and I knew it came from Broughton's lab, but I didn't know exactly who had done the dissection.
Yeah, it was exactly 23 years ago.
Yeah, it doesn't make incredible.
I'm going to put the first slide, so I know this figure.
Yeah.
Fantastic. No, from my point of view, fantastic. I'm extremely happy, Dr. Bellutini.
Last question about reconstruction. I didn't know if I heard you about lumbar drain in posterior fossa.
Oh yeah,
because
so we don't use it frequently. We use it on the patients that are recurrent CSF leaks. I don't use it on the first time. I may not use it on the second go. If we have a third go, I'm using a lumbar drain. So there are a couple of articles in the literature, right? So there's one from our colleagues from Pittsburgh, but you have to read the article in detail. They start with a baseline CSF leak rate of 35%. Okay, which is much higher than what we have as a baseline. And then with the lumbar drain, they decrease it to, I don't remember exactly, but it's somewhere between 10 and 15. That's my best baseline.
That's what we have now.
That's what we have. So it's 10%. So if the lumbar drain would have no morbidity, if I could put a lumbar drain and not have any complications with the lumbar drain, I think I would be using lumbar drains more frequently. But that is not the case. It has some morbidity associated with it. And that's why we don't use it exactly with every case. We're more conservative. And when we use it, yes, it makes a difference, but it's a very select population. Having said all that, you have to look at your numbers, and you have to look at where you're working and what you have before taking a decision. If I would be working in a place where I don't have the facility of bringing the patient back the next day, if I need to bring the patient back the next day, I would be thinking a little bit different from what I think nowadays. I would be using it maybe a little bit more frequently because I don't have the choice of taking that patient back immediately to do another repair. And again, look at your circumstances of your practice and take decisions based on valid data. Not really, you cannot apply my experience to your practice or the experience of anybody else to your practice. You have to look at it in a more systematic fashion on something that fits you, that fits your practice.
Well, we have been up and down with lumbar drain in the last 20 years, and especially for posterior fossa, we used to use more for posterior fossa, only for posterior fossa, prophylactically. One more question about pituitary transposition. What's the best technique, intra, extra, or interdural?
Oh, if you have the choice, extradural, for sure. Yeah, you will have the least number of TIs and least number of pituitary dysfunction if you can do it extradural. I would go even more. Even removing half of the pituitary as a way of getting there has less complications than the traditional transposition that was reported some years ago.
I agree completely with you, Ricardo. Yeah. The half transposition is much better.
Yeah.
Regarding the pituitary function, especially. Yeah.
Absolutely. So we avoid the true transposition as it was described by Amin many years ago. We avoid it because it's fraught with a lot of complications.
Yeah, absolutely.
We don't have so often to do a pituitary transposition. We think that to take the supraretinoid more for chordoma, extradural most of the time, is very hard for craniofaringioma that we had to do a
Mhm.
pituitary transposition to see the posterior fossa. It's very,
Yeah.
of course there is, but it's very rare. Ok. Gustavo, como é que nós estamos de tempo?
Bom, doutor, o Juan não mandou nada ainda por enquanto. Até first of all, I would like to thank Professor Carrau. He was very gentle to attend this meeting, and it was really impressive. It's nothing less than we expected from you. Huh? Really nice talk. I think that we had a very nice audience, around 60%, and it was really nice to have you here with us. And I hope we may have you other times here also, and maybe during our meeting, our Congress next year. Huh?
With pleasure. With pleasure.
E eu gostaria também de agradecer o Dr. Aldo, né, que pôde estar participando aqui. É sempre impressionante poder ouvir dele aí a experiência, e do Dr. Velutini. Eles formam uma grande dupla aí, né? Todos nós sabemos que é um grande time, né? Cláudio, eu acho que então a gente combina de fazer essa pausa, certo? Porque
Eu acho que sim, perfeito.
o
Eu
Juan
queria
não...
só brevemente falar que eu acho que essa é a essência da nossa sociedade, né? Você vê que foi um evento muito amigável, com assim interlocução muito fácil. Eu acho que espero que isso norteie a nossa sociedade, a gente criar esse bom clima, né? Como nós estamos vendo. Fiquei muito
Perfeito, Cláudio.
Gustavo,
agradecido
ficou,
pelo que eu
então?
vi.
Tá, então, assim, eu até gostaria de pedir desculpa aos outros participantes, né, pelo fato de que a gente teve um problema com o horário, e o segundo participante, o segundo palestrante, ele teve uma cirurgia grande, vai demorar um pouco para poder se juntar a nós aqui no webinar. Então, ele falou que conseguiria próximo das 8 horas da noite. Eu sei que fica ruim para todo mundo, mas infelizmente a gente não tem como postergar essa apresentação. Já foi difícil de conseguir organizar para hoje. Então, se todo mundo não é nem concordar, mas eu gostaria de pedir a compreensão de todos para nós fazermos uma pausa e voltarmos por volta de 10 para as 8, se for possível. Sei que nem todo mundo vai poder vir, a presença, se o Dr. Velutini, a gente sabe que ele tem bastante compromisso aí, que talvez não dê para adiar e participar da próxima aula, mas enfim, eu agradeceria se o senhor conseguisse, e de todo jeito já agradeço muito a sua participação, tá bem? Então nós voltaremos às 10 para as 8, e a presença, só para os outros participantes, a presença já foi computada por essa primeira parte, tá? Então, quem não puder já tem presença garantida, porque no final isso vai contar como um currículo, né? Então, para as futuras atividades da sociedade. Então, tá todo mundo já com presença computada. Quem puder vir, eu agradeceria muito, e eu acho que vai ser algo bastante produtivo, tá bom? Então, até daqui a pouco. Nós voltamos ao mesmo link, o mesmo login. Quem quiser deixar logado, pode deixar, não tem problema. E quem quiser logar mais tarde também é possível, tá bem? Um abraço aí a todo mundo, até daqui a pouco. O senhor quer falar alguma coisa?
Obrigado, Ricardo. Não, agradecer
Obrigado a você.
ao Carrau, obrigado pela aula aí, pela sua experiência. Acho que isso é extremamente importante,
My pleasure.
essas
My pleasure. And
informações.
congratulations for revamping the society and restarting again. This is really
Thank you.
very important.
Thank you, Ricardo. See you.
Hasta logo.
Bye. Bye para todos.